Thank you very much for the kind introduction. And I would like to, should I be here in the camera? Okay, I'm sitting correctly. Yes. Okay. So let's talk about Fabry disease and evolving concepts. And I have first to make some disclosures because of my relationship with pharma companies who have an interest in Fabry disease. And then let's go to the disease itself. So it's a genetic disease and it's a rare disease. And the fact that it is a rare disease is problematic from the point of view of studying its pathogenesis, its diagnosis, and its response to therapy. It is due to a genetic deficiency, a mutation in the GLA gene that encodes alpha-galactosidase A, which is an enzyme within the lysosome. So as a result of this deficiency, glycolipids accumulate in the lysosome and out of it. And it is X-linked. What does this mean? That men will have the disease as severe as it corresponds to the severity of the genetic defect. However, women's cells, they have two X chromosomes, and they randomly inactivate one of them. So very lucky women will inactivate mainly the altered chromosomes, and most or all of their cells will be healthy. And they can be completely asymptomatic for the whole of their lives. These are the true carriers. On the other side of the spectrum, unlucky women will inactivate mostly the healthy chromosome, and most or all of their cells will be Fabry cells, and they will have a disease as severe as men. And in between, there is a whole range of grays. So this is a source of heterogeneity in the presentation of the disease. There is a second source that depends on the severity of the mutation. So severe mutations will give rise to the classic form of the disease, with symptoms starting in childhood. However, less severe mutations will give rise to the non-classic or later onset form of the disease, with symptoms starting in late adulthood. And there is a further difference. In classic disease, the endothelium is full of glycolipid deposits. However, this is not the case for the endothelium of late onset disease. And this is quite a simple concept, but very important for the design and interpretation of clinical trials. As late onset patients will have the endothelium free of glycolipids, and women are mosaics of Fabry cells and healthy cells. We may represent a biopsy assessing endothelial deposits in a woman like this. So healthy endothelium, Fabry endothelium with deposits, healthy endothelium, Fabry endothelium, healthy. If we enroll this woman in a clinical trial and repeat the biopsy after an intervention, randomly, we may get a lower number of cells with deposits or a higher number of cells with deposits, because this is a mosaic. So you will not do the biopsy exactly in the same place that was biopsied before, mainly because that place is no longer there. And you may conclude that the therapy improved or the therapy got worse, but both samples may be from a woman on placebo. Okay, so now the question, what results would you expect for a clinical trial that enrolled a large number of late onset and female patients and had as a primary endpoint of the intervention endothelial deposits? Okay, was such a trial has been performed, in fact, and this is the population that it enrolled, a majority of females, many of them with later onset, mutational associated with later onset disease. It compared migalastat with placebo, and the primary endpoint was percentage of patients that have a response defined as over 50% reduction in the number of glycolipid inclusions in interstitial capillaries. And this was the result. So on therapy, 40% of patients improved. On placebo, 28% of patients improved. So if I was writing clinical guidelines for the therapy of Fabry disease, based on the results of this randomized clinical trial, I would say, first step, try a placebo for several months, because 28% of patients will improve. Obviously, that's not true. This is an artifact of a clinical trial enrolling a lot of females who are mosaics of Fabry cells and healthy cells. So this 30% that improve from placebo, likely the second biopsy picked up a section of the capillaries that had a higher percentage of healthy cells. So this is why the very basics of the disease is so important in clinical trials. Okay, now the natural history of Fabry disease in males. Why in males? Because males have the disease as severe as it corresponds to the mutation of the GLAD gene. And females have a whole range of presentations from this we are going to show to completely asymptomatic, the whole range. Okay, classic males. The disease manifestations will start in infancy. They will have neuropathic pain, what was called previously acroparesthesia. And this will be triggered by heat. So these kids will take off their socks and will try to put their hands on the floor because it's cooler. Then there are gastrointestinal symptoms, gastrointestinal pain, diarrhea. They have to run to the loo. They will have persistent fever. Whenever they have fever, instead of a couple of days, they may have fever for a week, 10 days, and this will be associated with neuropathic pain. So they will go repeatedly to emergency room because not because of the fever, but because of the pain associated with the fever. Eventually, they will stop sweating. So this is a history that can also be elicited. At some point, they could no longer do sports at school because as they were not sweating, they would overheat and not tolerate it. And finally, as teenagers, they will start noting these skin lesions, mainly in the bathing tract region and in the genitalia, which is the angiokeratoma, which is give rise to one of the names of the disease, angiokeratoma corporis diffusum. And mothers may note it or when there are these tiny spots of blood in the underwear, because there was some erosion in one of the skin lesions. Eventually, they will develop target organ injury, and natural history will die before the age of 60. This, when a dialysis is available, because kidney disease will lead to the need of dialysis at a mean age of 40 years, and later on, they will develop clinical manifestation of heart disease, like arrhythmia or heart failure. By contrast, in later onset disease, as I said before, endothelium is usually free of glycolipids. There are no childhood symptoms, and symptoms will start later on at around age 50, 60, and mainly refer to one of the organs, like for example, the heart, and not always the kidney. A third manifestation is central nervous system disease, like white matter lesions or stroke, that may be favored by arrhythmia, by atrial fibrillation because of heart disease. Okay, so this difference in the occurrence of kidney disease, both later onset and classic disease share the heart involvement, but kidney involvement may be milder, at least in some forms, some common forms of later onset disease. Okay. Given this information, would you use kidney function as an endpoint in late onset patients? So probably the response will be not, at least not for unselected later onset patients, maybe for those that in fact you have observed that kidney function is decreasing. Okay, and then we can summarize the natural history in terms of severe event-free survival. So survival in the absence of dialysis, in the absence of heart failure, in the absence of arrhythmia, in the absence of a stroke. And this is what we get. And clearly, there are two very different populations in the terms of event-free survival. On the one hand, you have classic males. They may start having these very severe events at around age 20-something. Before age 60, all of them will have these severe events. By contrast, classic females or later onset patients, there might be a lag time of up to 30 to 40 years without severe clinical events. Okay, so whenever you read the results of a clinical trial of Fabry disease, you should ask what patients are enrolled here. Are they classic males or these are the other patients? Because for the other patients, if you start treating at age 20, even in natural history, there may be 10, 20 years without any severe clinical event. So clinical trial, primary outcome, severe clinical events, you enroll later onset patients before the age of 20, you will not see events, even with placebo. So this is why classic patients should be started therapy as soon as they are diagnosed, even if they are children. Okay, then with this background, let's move to the recent advances in the understanding of Fabry disease, also with a parallelism of recent advances in the understanding of kidney disease. For example, in the 90s, we learned that proteinuria is a key driver of chronic kidney disease progression. The higher the proteinuria, the faster the loss of kidney function. We also learned that podocytes are the gatekeepers that prevent proteinuria. These are these cells that sit outside the glomerular capillaries, and we pay them for their mission is to prevent plasma proteins from leaking into urine. We also learned that the earliest manifestation of podocyte injury is albuminuria. So albuminuria will become pathological much earlier than proteinuria. And we know that it predicts outcomes. This is why the chronic kidney disease concept developed this century has two key parameters to assess to define the presence of chronic kidney disease. One, low glomerular filtration rate, or the other, pathological albuminuria. So you have pathological albuminuria, you have normal glomerular filtration rate, you have chronic kidney disease with the implication of chronic kidney disease. So this is an increased risk of premature death. And we have to remember that the current definition of chronic kidney disease was developed at around the time of the previous coronavirus outbreak. So in 2012, KDIGO provided this consensus definition of chronic kidney disease. More than 3 months, this is why it is chronic, presence of evidence of kidney damage, such as albuminuria over 30 milligrams per gram of urinary creatinine, or decreased glomerular filtration rate. Because these are the thresholds that mark an increased risk of eventually needing dialysis and increased risk of premature death. So despite normal kidney function, you may still have chronic kidney disease. And in the case of classic Fabry disease, I will say you will have chronic kidney disease despite normal kidney function and despite normal albuminuria, because you see there is this additional criterion here, abnormalities detected by histology. And all classic Fabry patients will have abnormalities detected by histology, that is glycolipid deposits. Okay, so where do these EGFR and albuminuria thresholds come from? I said before, they mark an increased risk of eventually needing dialysis and for all cause and cardiovascular death, premature death, because we are all going to die, unfortunately. Okay, and what about advances in the understanding of Fabry disease? Well, at the start of the century, we thought that endothelial cells were the key cell types in the pathogenesis of Fabry disease. This is why early clinical trials had as an outcome measures the clearance of glycolipid deposits from endothelium. And this makes sense because patients enrolled in the early clinical trials were mostly classic males. but this does not make sense any longer when you enroll in trials females which are mosaics of healthy and Fabry cells, or when you enroll later onset patients who have very few or even absent endothelial deposits. So if you have absent endothelial deposits, what's driving target organ injury late onset? Or we may even extend the question to classic patients. These are the results of the pivotal studies of agalsidase beta. It cleared endothelial cells within a 6-month period at a dose of 1 mg per kg every other week. And this was also the case for agalsidase alpha at dose which was 5 times lower. So these are endothelial findings, but they may not apply to podocytes. If you think about it, if you inject enzyme IV, the first cell type that the enzyme will find is endothelial cells. So it's the access of enzyme to endothelial cells is quite easy. The enzyme gets into the bloodstream, finds a cell, which will be endothelial cell, gets inside. But what about cells that are outside of the vessels? What about podocytes who are sitting outside the glomerular capillaries? What about cardiomyocytes? Well, access will be more difficult there. So the fact that an enzyme and a dose clears endothelial cells does not automatically mean that will clear additional cells. And then findings started to point to podocytes, at least in the kidney field. And we must emphasize that some heart cells, for example, share some properties with podocytes. Podocytes are very long-lived cells. So this is also the case for the cardiomyocytes. Okay, so it was found that very early on in children, there were already huge glycolipid deposits in podocytes. Much larger, these deposits, than those found in the endothelial cells. Moreover, these deposits correlated with proteinuria, even when proteinuria was still within the physiological range. And more studies demonstrated that proteinuria is a major risk factor for progression of chronic kidney disease in Fabry disease. No surprise here, because it's the same as for any other proteinuric kidney disease. So the higher the proteinuria, the faster the loss of glomerular filtration rate. And proteinuria means injured podocytes. So I see this like a kind of snowball down a mountain. You have seen here in this graph the glomerular filtration rate trajectories of patients who have progressively increased proteinuria. And each line represents different patients. But this may also represent the trajectory of a single patient that would start up there, no proteinuria, relatively stable GFR, but then proteinuria develops. And for the next 5 years, GFR will be lost faster. And then proteinuria increases, and the GFR will be lost even faster and even faster until they eventually get to dialysis. So this is natural history for males, not in females. This is the same graph for females. And you can see here that kidney function remains quite stable until proteinuria increases above 1 gram per gram of urinary protein. In which case, GFR is lost a little bit faster, but not so fast. So when you study a large group of unselected women with Fabry disease, you will not see CKD progression, or it will be very difficult to demonstrate because it's been lost quite slow. And why is that? Well, likely because women are mosaics of healthy and Fabry podocytes. So even if all the Fabry podocytes are lost, if there is still a large number of healthy podocytes, this will not result in progressive kidney disease leading to dialysis. Okay, and here it is represented the natural history of a Fabry disease in a large population of males. And you see that as proteinuria goes up, glomerular filtration rate goes down, and the mean age that dialysis need is 40 years. And when you look at males and females, again, the mean age at dialysis need is around 40 years. So there is some variability, but this is the mean and both, and also the median age. And you may say, oh, you just told us that females, when you assess a large group, they are not progressing, but now you are showing us females on dialysis, and they may do get to dialysis, but look at the numbers. There are roughly 10-fold less females needing dialysis than males. So indeed, some females will lose kidney function fast, but if you want to study the impact of an intervention of kidney function in females, you must first select for females that are actually losing renal function. Because in a large group of unselected females, kidney function will be mostly, for the most part, stable, even in the absence of intervention. Okay, so with this background, who should be tested for Fabry disease in nephrology? So there are some suggestions that every male with chronic kidney disease, especially if young, and by this it is meant below the age of 50, it is recommended to screen for Fabry disease if there is an absence of a reliable renal diagnosis. So if there is no sonography showing cysts, if there is no kidney biopsy showing a glomerulonephritis, if there is no diabetes with a typical diabetic kidney disease progression, typical of diabetic kidney disease. And in females, this is also the same, especially if they had other symptoms suggestive for Fabry disease. Okay, so from a point of view, this is the key cell type in Fabry disease, at least for the kidney, the podocyte. It's sitting out there, preventing albumin from leaking into the urine. And this is evidence of the involvement of podocytes. Kidney biopsies from children from age 3 on. And you see that as they get older, they accumulate glycolipid deposits in podocytes in higher amounts than in endothelial cells. Moreover, the amount of deposits in podocytes correlated with proteinuria in children. And moreover, in kidney biopsies, there was evidence of podocyte injury, that is segmental foot post-recessive basement, or glomeruli, already in children. And what you are seeing here, this is an anemone. And this is an animal that is immortal. So it will not die in nature. You have to actually kill it, cook it, cook it, whatever. And there are a lot of studies going on why these animals are immortal. So podocytes should be immortal, at least during our lifetime. These are terminally differentiated cells that, like neurons, they do not divide, and they should be with us for 30, 40, 80, 90 years. And if they don't are with us for so long time, maybe we will need dialysis before leaving this world. So they have a lot of years to accumulate huge amount of glycolipids. So huge amounts of glycolipids that you can actually see them in a fresh kidney biopsy. So this is a fresh kidney biopsy cylinder under high magnification, but not under a real microscope. And you can see these balls, which represent the glomeruli, that in normal people, they are red. Glomeruli are balls of capillaries, and you can see the red blood cells inside. So in normal people, you see the glomeruli in the fresh kidney biopsy red. But here they are white, and you can actually see the actual podocytes full of glycolipids. They have so much glycolipids, that's fat, and fat is white, that you cannot see the red blood cells inside. So if you ever perform a kidney biopsy and see this white glomeruli, you can go to the pathologist and say, dear pathologist, I think I'm bringing here a kidney biopsy from a Fabry patient. Please look it carefully under the electron microscope. Because in electron microscopy, you see the podocytes full of glycolipids. This is not the case for optical microscopy. If you process the sample for optical microscopy, the lipids are washed away. So you will only see empty spaces. And the pathologist may not make the connection to Fabry disease. The pathologist may think about osmotic nephrosis or other alternative causes and may miss the diagnosis of Fabry disease. So if electron microscopy is performed, there is no way you can miss Fabry disease. And you see this podocyte still has healthy food processes. But just the adjacent podocyte, also full of glycolipids, has food process effacement. So this is a cause, in fact, of secondary focal segmental glomerulosclerosis. And some patients, after having been biopsied, have this diagnosis, focal segmental glomerulosclerosis. And what you see here, this is not what it seems. So this is no hooligan fooling around in the toilet. This is a cell biologist that knows that whenever he pees, he's losing podocytes in urine that will never come back because they do not divide. So he's taking some distance to say bye-bye to his podocytes. And please remember this when you go to the toilet after the conference, because we all are missing podocytes that they will not come back. And each time we lose them, we are a step closer to dialysis. And some people will lose all their podocytes before leaving this world. They will need dialysis, and some will not. So some people lose podocytes at a faster rate. And this is the case, for example, for Fabry patients. And this is how it works. So when they get older, their podocytes start accumulating glycolipids. Initially, there will be empty spaces inside the podocyte, but eventually the full podocyte will be full of glycolipids. At this point, the concentration of podocyte glycolipids can no longer increase, and they will start to be lost in urine at a higher rate. And when they are completely full, podocytes will enlarge to accumulate further glycolipids. Okay, then I want to introduce another molecule, which is lyso-Gb3. At the start of the 20th century, it was known that in Fabry disease, Gb3 was accumulated in lysosomes. But we had a problem here. That was that Gb3 levels in plasma were not so higher. So you had Fabry patients in whom the circulating levels of Gb3 were in the same range as for controls. So it was not a very good marker of response to therapy because there was this overlap with controls. And then lyso-Gb3 was described by hand Aerts. And you see the concentration is much lower of lyso-Gb3 than of Gb3 in plasma. But the difference with controls is larger. And in fact, there is no overlap for males between lyso-Gb3 in controls and Fabry patients. And it may be used to confirm the diagnosis of Fabry disease when the genetic tests provide a genetic variant of unknown significance. So if lyso-Gb3 is high, that will be Fabry disease. If lyso-Gb3 is normal, it will likely be a genetic variant which is benign, polymorphism. When you look at females, complete overlap of Gb3 and virtually no overlap for lyso-Gb3. There are a couple of females here that have normal levels of lyso-Gb3, but maybe these are the real carriers of the disease, that they have the Fabry gene, but most or all of their cells are healthy cells because they have inactivated the Fabry chromosome, and they are actually healthy. I want to show you something else. This is exactly the same slide as before, but we are using the same scale for males and for females. You see, the 100 is here for both. So what we learned, that lyso-Gb3 levels are much higher in males than in females. And these are classic patients. Okay, so females have like 10-fold lower levels than males, they also have like tenfold lower risk of eventually needing dialysis. So there appears to be a relationship between levels of lyso-Gb3 and severity of disease. And this is another image representing that. So these are Japanese data, and they looked at the enzyme activity for wild-type enzyme, for benign polymorphisms, for enzymes associated, for mutations associated with later onset disease, and for mutations associated with classic disease. And this is the mean plasma lyso-Gb3 levels for the different mutations. And you see that there is a relationship between the severity of the mutation as assessed by enzyme activity and the plasma levels of lyso-Gb3. Okay, so from my point of view, lyso-Gb3 levels are associated with the severity of the disease. But then this is a rare disease, and so you have a lot of publications there with a low number of patients that maybe all of them, they may be classic patients. So if you take out of the equation all the patients with less severe disease and lower lyso-Gb3 levels, it will be more difficult to demonstrate a relationship between lyso-Gb3 and severity of disease. But you also have this. If this were a boy with classic Fabry disease, with a very high lyso-Gb3 level, but still young, and this amount with later onset disease, much lower lyso-Gb3 levels, but much longer time exposed to these lyso-Gb3 levels. If you mixed both of them in the same group of patients, you may conclude there is no relationship between lyso-Gb3 levels and severity of the disease. But you also have to take into account time of exposure. So we know that Fabry disease has a very long natural history. 40 years in the case of kidney disease, which is the earliest organ to fail. So either you assess patients who have the same age to assess the relationship between lyso-Gb3 levels and outcomes, or you assess the lifetime exposure, that is multiplying the lyso-Gb3 levels for the age. And there is evidence, there is preclinical evidence that lyso-Gb3 contributes to the pathogenesis of Fabry disease. So I'm showing here data for podocytes, but similar data have been generated for cardiomyocytes and also for neurons. So when you expose cultured human normal podocytes to lyso-Gb3, several pathways are activated, including the autocrine secretion of TGF-beta1 and increased production of extracellular matrix, recruitment of the NF-kappa B pro-inflammatory responses, and recruitment of the Notch-mediated pro-inflammatory responses. And you know what? This stress response elicited by lyso-Gb3 in podocytes is exactly the same as elicited by another metabolite that accumulates in another disease that is associated with proteinuric kidney disease, which is diabetes, and in this case, the metabolite is glucose. Okay, so now we have podocytes at the center of the pathogenesis of Fabry disease, and now we get a different question. So the start of the 21st century, enzyme replacement therapy became available, and the research question was, does it clear endothelium? But now we have become aware of the central role of podocyte injury in Fabry nephropathy. So the question is, how does therapy clear podocytes? And there is evidence from repeat kidney biopsies that the reduction of podocyte Gb3 deposits correlated with the cumulative dose over the years. In this study, you see in the horizontal axis years, vertical axis glycolipid deposits in podocytes. Each point is a kidney biopsy. And patients were divided in the lower fixed dose group, in which some clearance of podocytes was achieved, but not a single patient completely cleared podocytes in up to 13 years of follow-up. And there was also a higher dose group, in which some patients completely clear podocytes and some have this pattern of clearance and reappearance. So what was the dose? Lower fixed dose group, 0.2 mg per kg every other week. Higher dose, anything above 0.2. So you see the 0.2 is up here, the 0.2 down there. Now we have the same scale. So when you treat patients with 0.2 mg per kg every other week of phagalsidase, of recombinant alpha-galactosidase A, not a single patient clear podocytes over the years. When you use higher dose, very different results for very different doses. Anything about 0.2 was called higher dose. So let's look at individual patients. For example, this patient in black here, completely clear podocytes, was the full time on 1 mg per kg. This light blue patient here, completely clear podocytes, while he was in 1 mg per kg, podocyte deposits came back in association with a decrease in dose to 0.2. And then the dose was increased again, and deposits came back down again. But you have here this dark blue. No glycolipid clearance whatsoever in 13 years in the higher dose group. But when you actually see the dose, it's 0.2 for many years, 1.0 for 1 year, 0.4 and 0.2. So even within the group of the higher dose, there was a relationship between dose and podocyte clearance. But mind that endothelium was cleared in all. As expected, it only takes 6 months to clear endothelium. And additionally, the residual plasma lyso-Gb3 also correlated with dose. So the higher the dose, the better you clear podocytes of glycolipids, the better you reduce lyso-Gb3 in men. As a result of these studies and the studies assessing the importance of albuminuria with outcomes, albuminuria is now a treatment criterion. At the start of the century, proteinuria was required, for example, to initiate therapy for Fabry disease in females. Now it's just pathological albuminuria which is required, or even with normal albuminuria if there is histological evidence of tissue injury. Moreover, decreasing albuminuria and decreasing podocyte deposits are also targets of therapy. And as for other proteinuria kinases, we have tools that improve outcomes by preserving kidney function and decreasing albuminuria. And this is, for example, RAS blockade. So these are patients who have Fabry proteinuria kinases before enzyme replacement therapy became available. So they were on RAS blockade, but they continued to lose renal function. Then they were starting on agalsidase beta 1 mg per kg, and with the combination of non-specific RAS blockade and agalsidase beta, kidney function remained stable. And now a further food for thought. What about Sglt2 inhibitors? That they have shown to preserve kidney function in both diabetic and non-diabetic proteinuria kinases. Should we add Sglt2 inhibitors to non-specific nephroprotection to Fabry patients? Well, a case might be done for it. And I guess what we should do, if we do it, we should document it so as to be able to report it. And here we come back to this fact that we have learned also in recent years, it's that the risk for severe kidney disease depends both on sex and on the severity of GLA mutations. And again, this has implications for clinical trials. So there are already several manuscripts out there that have studied late onset mutations, and the most common European late onset mutation is N215S, which is mainly found in Germany and the UK. And the publications generally concur that there is no or very mild CKD progression. So some patients do get to dialysis, but it's quite unusual, and most of the time they have a mild decrease in GFR without actually ever getting to dialysis. And what about classic females? We also saw before some evidence that as a group, kidney function remains stable. And there was this recent publication in which late onset females were excluded. So we are just looking here at classic females. Moreover, we are looking here at females that have severe disease severe enough to start enzyme replacement therapy. And we are looking at the slope of the loss of GFR before starting ERT. And you see it's stable. So they are losing 1 ml per min per year, which is the age-associated loss of eGFR. So if you ever try to test whether a therapy for Fabry disease is preserving kidney function in Fabry females, please enroll females that are already losing renal function. Because in an unselected group of females, any therapy will result in stable renal function. And this maybe at this point, I think we may remember this clinical trial that what was actually performed. Parachute used to prevent death and major trauma when jumping from aircraft, a randomized control trial. I don't know whether you are familiar with this trial. Okay, so the conclusion was that parachute use did not reduce death or major traumatic injury when jumping from aircraft in the first ever randomized evaluation of the intervention. Is that surprising? However, the trial was only able to enroll participants on a small stationary aircraft on the ground, suggesting cautious extrapolation to high altitude jumps. Okay, so this may seem funny, but this actually has taken place in the Fabry disease world. So then the authors get serious. When beliefs regarding the effectiveness of an intervention exist in the community, the randomized trials might selectively enroll individuals with a lower perceived likelihood of benefit because they are considered to be a lower risk, thus diminishing the applicability of the results to clinical practice. So this is one of the participants. And this is the case with, so when you look at the characteristics of participants in more recent clinical trials for Fabry disease, you don't see here, you don't see there the males with classic disease, severe pain, etc., that you saw in the early clinical trials at the start of the century. Instead, you see females in their 50s with normal renal function, no proteinuria, no pain, etc. So the extrapolation of the results from these trials to the actual wider Fabry population, patients with severe classic disease, etc., well, we should be cautious. And then I will show data that agalsidase beta 1 mg per kg is an optimal therapy to decrease hard adverse kidney outcomes in the long term. And these data are from a randomized clinical trial, which is the Canadian Fabry Disease Initiative. So this is a head-to-head agalsidase alpha 0.2, so versus beta 1 mg per kg. So this is the official doses of both enzymes. Randomized clinical trial with primary endpoints severe clinical events, cardiac, neurological, or kidney events, or death. And this is the report of the 10-year outcomes. And this was a 10-year trial, mainly because they had funding from the Canadian government to run the trial for 10 years. And the estimated sample size was 600, okay? And they enrolled 132 patients. Now, please tell me what was the result of the trial. If you need 600 patients to observe statistically significant differences, but you enroll 132, the result will be no statistically significant differences. Okay, it's an underpowered trial, severely underpowered trial. And indeed, this was the case for cardiac or neurological events or death. And also, this was the case for kidney events in females, which were very uncommon. By the way, they were very uncommon. The most common events were kidney events in males, which makes sense because chronologically kidney events occur earlier than heart events. So these were the more common events. And they were defined as need for dialysis, doubling on serum creatinine, or nephrotic range proteinuria. And this was the surprising results for severe kidney events. Fourfold less on a calcium beta 1 mg per kg than on a calcium alpha 0.2 mg per kg. Fourfold less. Highly significant. How come it is highly significant when the trial was so underpowered? Well, the difference was not 20% lower, it was not 50% lower, it was fourfold less. But it took 10 years to demonstrate. Why? Because of the natural history of the disease. It takes 40 years to get to dialysis. So you likely will not see differences in shorter trials. Okay, now the next question. Okay, these are the results from the trial. Can I believe these results based on what I know about the pathogenesis of Fabry disease? Is there a biological plausibility for the impact of ERT dose on kidney function? And I would say yes, because we know that the impact of dose of enzyme on podocyte glycolipids is so the clearance of podocyte glycolipids is dose dependent, and also we know that the lowering of lyso-Gb3 is also dose dependent. And this is a further example. So these are patients that were on agalsidase alpha 0.2 mg per kg every other week and were switched to beta 1 mg per kg. And this is lyso-Gb3, and you see there is a dramatic decrease. In some patients, it is really dramatic, and these are the patients who had anti-agalsidase antibodies. So when you are missing a protein and you provide the missing protein, it may be recognized as foreign, and this may be the case for patients with severe Fabry disease. But you see this pattern, large drop of lyso-Gb3 within the first months, and then a slower drop thereafter. Large drop initially, slower drop thereafter. Why is this? So there is some discussion as to why is this, but one possibility is there are like two pools of lyso-Gb3. One that it is easily accessible, and another that is not so easily accessible. And quite recently, the podocyte, it says here lyso-Gb3 is a mistake, podocyte Gb3 on agalsidase beta. Quite recently, the pattern of clearance of podocyte deposits in the early months after initiation of therapy on agalsidase beta 1 mg per kg was described. And indeed, we saw before the repeat biopsies up to 10 years later. But when you look at the early response, there is a large decrease in podocyte deposits. This is not lyso-Gb3, again, this is Gb3, in a first few months, and then a slow further clearance over time. So this pattern that we see on circulating lyso-Gb3 mimics the pattern of clearance of deposits in cells that are difficult to clear at podocytes. Okay, and then a couple of a reminder of chronic kidney disease as a pediatric manifestation of Fabry disease. What we see depends mainly on what we look for. So in children, we have to look for albuminuria, not dipstick proteinuria, because proteinuria occurs later, but also because these children may have a urine concentration defect, that anything in urine is diluted, including proteins. And then anticipate the difficult by managing the EC, I would say. And there are two reports of very early start of agalsidase beta 1 mg per kg in children that normalized lyso-Gb3, an outcome that cannot be achieved in adults. So the earlier they start, the better, probably depending on these cells like podocytes that accumulate such huge amount of glycolipids. So when you start, when they have not yet accumulated such huge amount, the results will be better. So this is, I think, the evidence points to the fact that agalsidase beta 1 mg per kg is the optimal therapy to decrease heart adverse kidney outcomes in the long term. A couple of stress slides. Only agalsidase beta is available in the US, not agalsidase alpha. And here, this is the Netherlands protocol for Fabry disease. Given a more robust reduction of the biomarker isolation GB3 and potential better effect on cardiac hypertrophy and complication rate in agalsidase beta versus agalsidase alpha treated patients, in most patients, agalsidase beta will be prescribed. What about the chaperone? Migalastat is SEMA-approved, but the Dutch Ministry of Health has decided against reimbursement given the lack of robust evidence on its therapeutic effectiveness. So on this, with this background, a further question. Let's focus just on enzymes. So there are two enzymes out there. You may choose the enzyme for your patient in front of you. And we are seeing papers reporting real-world evidence with all kinds of results. How to interpret that? So how would you decide to treat your patient? And there is these three possibilities. A, you use the enzyme that is used at a higher dose for the more severe patient. B, you use the enzyme that is used at a higher dose for the less severe patient. Or C, random assignation. What do you think is taking place? What would be expert opinion? So if you want to know expert opinion, don't ask the experts, just look at what they do. And we are quite lucky because experts made this recent publication on agalsidase alpha 0.2, agalsidase beta 1 mg/kg multi-center observational studies. The Champions League of Fabry centers in the Netherlands, the UK, Germany, and Canada. So how they distribute agalsidase alpha and beta between their patients? Well, out of 100 patients on beta, more than 50% were classic males. Out of 100 patients on alpha, less than 1/3 were classic males. So most patients on alpha are later onset or females. So the correct response is A. So large centers, the ones that are making the publications, are assigning agalsidase beta mainly to more severe patients and agalsidase alpha mainly to less severe patients. So they recognize that there are apples and oranges, and they treat them differently, which creates a problem for us to interpret the literature. There appears to be a systematic bias in observational studies in the literature regarding the severity of disease of patients on alpha and beta. So you see here the two humps of the camel, two different populations of Fabry patients that are being treated with different enzymes and results reported. So you cannot actually compare what's in the literature for one enzyme and the outcomes with the other. You can only trust clinical trials like the Canadian Fabry Disease Initiative. Okay, so this is the take-home message. We have moved from a Fabry literature focused on classic males to a Fabry literature with a lot of data on females and late onset patients, but mixed up with classic males. We can only interpret the trials or the studies where these populations are clearly differentiated. We have moved from clinical trials enrolling classic males from clinical trials enrolling females and late onset patients. We cannot compare the results of these two types of clinical trials. Real world data were initially referred to classic males, and now we have moved into a mixture of patients, and there is a bias according to the therapy that they are receiving. So patients that are being treated with migalastat cannot be compared to patients on agalsidase because the mutations are different. And patients on alpha and beta cannot be compared with, because we are seeing that expert centers, the one who do the publications, assign one or the other enzyme based on the severity of the patient. We have moved from the endothelium to podocytes and from GB3 to lyso-GB3. Thank you very much for your attention.
the possibility to ask you some questions. Ci sono domande dalla sala. Let's see if somebody from the So nothing in the chat. I see Dr. Pieruzzi. Federico, ho visto che ci sei e ha anche la mano alzata, quindi può parlare.
Yes, grazie. Hi Alberto. How are you? Nice to see you. I'm sorry I could not be there in person.
Hi.
I appreciate very much your presentation as usual. Very, very keen. And you introduced a nice concept that I think deserves a little more detail. And you'd said that lyso-Gb3, we should, instead of just taking the dosage, but consider the exposure, right? And just
Yes.
correctly. But
Yes.
this is very true, I believe, but might be a bit difficult to estimate or to measure. Do you have any idea of how we can, in a way, use this concept in practice?
Yeah, I think the simplest way would be to multiply the value we have, ideally a value pre-therapy, by the age of the patient. So okay. we know from Italian studies of neonatal identification of Fabry patients that in the first few years, lyso-Gb3 levels go up, so they are not stable. But as we currently lack lyso-Gb3 levels over the years in natural history for patients, I think we should try to extrapolate some way, and the easiest way would be multiply age by lyso-Gb3 levels. Because otherwise, if you compare a child with very high levels, well, lyso-Gb3 levels are very high, but he did not have the time to develop the disease. It's the same with mice. So we don't have a good mouse model of Fabry disease because mice live 2 years and it is too short to develop target organ injury.
Yes. And if I may ask another question again on the same subject, is how in your clinical experience, how do you interpret subtle changes of lyso-Gb3 in your follow-up patients, independently whether they are on treatment or they're not on treatment? I mean, do you use lyso-Gb3 in regular follow-up visits and make your decisions in terms of if they change and how they change?
Yeah, I think ideally we should have a baseline value and a value at around 3 months, 3 to 6 months. There we should see a dramatic drop. If we don't see a dramatic drop, we are in trouble. And after that, I think assessing once a year would be okay, because what we would expect is a slow decrease. So if we assess within a shorter interval, we may start to see these ups and downs. If at some point it starts going up, we also have an issue, and this may occur between month 6 and 12 by the development of antibodies, especially in patients who are on agalsidase alpha, which is at a lower dose. Multi-lenders recently showed that in patients who develop antibodies, the dose of enzyme is important in order to overcome the antibodies, in the sense that patients on a higher dose, during the infusion, antibodies at some point disappear because they bind the enzyme. At some point, your infusion enzyme in the absence of antibodies. However, if the dose of enzyme you are using is low, you will have circulating antibodies during the full duration of the infusion. So all the enzyme that is getting into the body will find antibodies. And this has associated the finding of antibody-free period of the infusion versus antibody presence during the full infusion. He has associated this with outcomes and also with lyso-Gb3 levels.
Great, thanks a lot, Alberto.
Thank you.
So, Alberto, would you check antibodies only when lyso-Gb3 levels increase, or should we do that on a regular basis?
Well, that's a good question. I think it's still unsolved in the Fabry field. And I say it's still unsolved because what are you going to do with the results? So if you are on oxidase alpha 0.2, you may switch to oxidase beta 1.0, and you know, and at least there are data that this may help. But what if you are on oxidase beta 1.0? And I think we need studies addressing this regarding potential use of immune suppression regimes, or better still, we should be defining the CRIM-negative situation in Fabry disease as they do for Pompe. So we should know whether a patient has any protein at all encoding alpha-galactosidase A, because if they don't have, maybe we should use test, I mean, this is research, protocols for the development of tolerance as they do for Pompe. Because in Fabry disease, there will not be any adverse outcome in the short term, because it's a very long natural history. But eventually you may get into trouble if for many years you are using a suboptimal dose of enzyme, not because it is suboptimal regarding the regulatory authorities authorization, but because it is suboptimal by the presence of antibodies. So I think the impact in Fabry disease is not as dramatic as in Pompe, and we are missing on that because of the long natural history. But probably it has an impact on patient outcomes. And likely this, some of the treatment failures and some of the progression of disease might be related to antibodies that once they develop, it's difficult to get rid of them, but it is easier to prevent the development of these antibodies in the first place.
And I have another question. What about the lyso-Gb3 levels in patients treated with migalastat? Is there any usefulness to?
Okay, so that's a very good question, and there is some evidence there. For example, Malte Lenders has this paper that I think I have it. I may yeah. So the official line by the laboratory and by people who are happy with migalastat is that it is not useful because migalastat will increase the amount of enzyme in lysosomes, and somehow lyso-Gb3 is outside lysosomes. I don't really buy that, because lyso-Gb3 is generated from Gb3, but by a lysosomal enzyme. So we measure lyso-Gb3 in plasma, but it actually being generated inside lysosomes. And then we have this data from their clinical trial. These are data from the pivotal clinical trial of migalastat. As you know, during the trial, they changed the definition of amenability. Okay, so they enrolled in the trial some patients that they thought they were amenable, but they turned out not to be amenable. And this is what was the evolution of the lyso-Gb3 levels in these non-suitable genetic variants. Lyso-Gb3 went up, okay, most of them. In this one not, but in others it went up to over 60 nanograms per minute, so huge increase. So there is evidence from the migalastat trial that when the genetic variant is not responsive, there is an increase. This is easier to see in males. So you cannot see an increase in almost 70 in a female because baseline, the value will be 5 to 10. And you cannot see an increase of 70 in a later onset because baseline, the value will be much lower, okay? But we have this evidence from this from this clinical trial. Then there is this genetic variant, which is amenable officially by the official test to explore amenability. But Lenders et al. Studied the amenability in the patient cells. So they didn't study the amenability in the official test to assess amenability. They took out the patient cells and they studied amenability there. And they could not reproduce the amenability. And why would they do that? Because clinically, they had these 2 males over here and 2 females down there And these are lyso-UV3 levels, and they were on ERT. These are males and these are females. And you see, there is up and downs, but globally, it appears that it's going down over time. Then they switched to migalastat, and lyso-UV3 went up. And went up, and it reached a peak. Well, it went up over 15 months. It went up higher and higher and higher. Okay. And in the females that were decreasing, it stopped to decrease. So you see, it's more difficult to see the impact on females. Okay. But in males, it was quite obvious. And then there is the discussion, well, this is because migalastat, the mode of action, etc., etc. Well, they switched back to ERT and it went down. But what triggered this assessment of amenability and lyso-UV3, etc., was the clinical observation that albuminuria more than doubled in the two males. Okay, so from my point of view, if you switch to migalastat and lyso-UV3 goes up, I think you are in big trouble. But I understand that people are disputing this. Okay.
That's an excellent answer. Thank you very much. One last question. What do you see in the future of treatment of Fabry disease? Because there are new drugs coming up. So what is your feeling?
Yes, well, yes, let's see. So lucerastat was being developed, and apparently they have stopped while they rethink based on the negative results of their trial. Let's see what Peguni Gatsidis has to say, and we have also
that is the long-acting enzyme.
A long-acting enzyme, but likely a combination therapy. So sometimes I imagine the glycolipid deposits like a bathtub, and you have the tap that you can open more, and you have the drainage. So in Fabry disease, the drainage is blocked, so the bathtub will fill up with glycolipids. And therapy is aimed at solving the drainage blockage by providing enzyme. But we forget about the tap. So it's not the same to have the tap full open or almost closed. So the association with a glucosylceramide inhibitor, like lucerastat or venglustat, with enzyme replacement therapy, I think might be of interest. And sometimes I think that we should have an approach like for cancer or for HIV. So hit hard from the start with several agents and then do maintenance with one of them. So we know that with enzyme replacement therapy, it takes years to clear podocytes. Why wait for years? When you may close the tap with glucosylceramide inhibitor and simultaneously open the drainage and accelerate the clearance. So that might be one strategy. And then likely some kind of genetic therapy in the future can actually cure the disease, although the current ones, all of them have issues.
Now I have another question again. What about repeating kidney biopsies or skin biopsies to monitor the disease? What is your position on that?
Well, I think if you are going to repeat, likely kidney biopsies, because skin biopsies, you will be assessing mainly the endothelial cells that supposedly are quite easy to clear, and they will be cleared by any therapy. If they are not cleared, you are in big trouble again. And repeat kidney biopsies, this is the philosophy of the Bergen group that has provided much of the data on repeat kidney biopsies. And for them, it clearly demonstrated that agalsidase beta 1 mg per kg is clearly superior to agalsidase alpha 0.2 mg per kg. And this is also the reason why all other agalsidases that are being tried at the dose of 1 mg per kg. However, it is invasive, so I'm reluctant to recommend it for all patients.
So more for research than for clinical practice.
Yes, because the other thing you need is a good pathologist that is able to quantify. And there is a catch there, because as podocytes balloon when they accumulate huge amount of deposits, they balloon and they are full. When they start to clear, they lose size, but they continue to be full of deposits. Okay, so unless you have this three-dimensional evaluation of podocyte volume and deposits volume, you are going to miss the initial decrease in glycolipid deposits. So if you are going to perform repeat biopsies, you need a very good pathologist that on a three-dimensional manner can evaluate the volume of deposits to optimally assess how they are being cleared.
And what about using electron microscope of the urine when you see by podocytes?
Yeah, yes, there you can see podocytes and you can see whether they are full or not of deposits. I don't know whether that has been tried, but again, maybe you are seeing the worst part of it. So probably the podocytes that are still full of deposits are being cleared, but you are being lost. You're not quite sure whether the remaining ones are in better shape. So that might be a possibility, but it should be addressed and tested.
One question over there. C'è una domanda?
Thank you very much for the presentation. I have a curiosity about the relationship between the cardiac event and the renal event. So, if I have understood, you said that cardiac events follow always.
Generally, yes. Yes. So for events, we mean clinical impact. However, we know that left ventricular hypertrophy starts quite early, so in their 20s. The first manifestation of target organ injury is usually albuminuria in the teens. Then left ventricular hypertrophy may be detected in the 20s, but the actual event of an arrhythmia, heart failure, etc., takes place later. But this is not really associated with kidney disease because in the classic patients, the usual sequence is kidney disease and heart disease, but in the late onset, they may have very severe heart disease with quite mild kidney disease. So GFR, for example, over 60. And still, they are in their 60s and they have very severe left ventricular hypertrophy, heart failure, arrhythmia, etc. Ventricular arrhythmia potentially lethal. This is what's thought. The thought is that it is being taking place, but likely this accumulation changes the biology of heart cells. So there is some discussion as to what extent the left ventricular hypertrophy can be explained by just accumulation of glycolipids, and it appears that the amount of glycolipids is quite low related to the extent of left ventricular hypertrophy. So there is actually a triggering of left ventricular hypertrophy so the thickness of the heart does not represent just a lot of deposits there. There is actual hypertrophy taking place.
Thank you very much.
Thank you.
Grazie mille. There is one, maybe, let's see in the chat. Oh, that's a technical issue. We will answer to that. Therefore, this ends the first part of our meeting. Now we will have, abbiamo una seconda presentazione. Quindi io interromperei la condivisione.
Prof, mi deve abilitare per la condivisione.
Sì, non riesco a capire come fare a interrompere la controlli riunione. Eccoci qua. Adesso puoi condividere, pensi?
Dice che sono disabilitata ancora.
Francesca, come facciamo ad abilitare?
Salve prof, sono Gianmarco. Bisogna mettere Costanza come co-organizzatore, quindi basta premere su Costanza sulle opzioni e metterla come
Indico
co-organizzatore.
organizzatore?
Sì, esatto. Dopodiché lei può condividere lo schermo.
Ok, prova adesso.
Ok.
Ottimo, grazie Gianmarco.
Niente.
Ora Costanza Conti è una specializzanda della scuola che lavora qui al Sacco e che si occupa di malattia di Fabry assieme alla dottoressa Sabrina Caruso, che non può essere presente fisicamente qui per un problema di malattia. Anche Costanza ci segue da casa e presenterà brevemente il nostro centro con le sue caratteristiche. Costanza.
Buongiorno a tutti, ringrazierei Prof per l'opportunità di essere qui con voi oggi e con il professor Ortiz. Nella mia presentazione descriverò appunto la rete dei pazienti con malattia di Fabry all'interno della nostra azienda sociosanitaria. Non va. Prima di tutto volevo dedicare qualche minuto al ricordo delle donne vittime di violenza, in quanto oggi appunto è la ricorrenza è la giornata internazionale per l'eliminazione della violenza contro le donne, una tematica ancora oggi molto importante che non rappresenta un fenomeno episodico emergenziale, bensì ben strutturato ed endemico. Proprio per questo l'Università degli Studi di Milano già da tempo è impegnata in iniziative volte al contrasto della violenza di genere ed attualmente è partito un progetto che si chiama Osservatorio Violenza sulle Donne, che ha l'obiettivo di creare una stretta collaborazione tra l'ambito accademico, giuridico e centri antiviolenza proprio per sensibilizzare noi tutti su questa tematica. È un progetto volto non solo agli studenti ma anche a tutti quelli interessati e alle vittime di violenza e quindi vi segnalo la pagina nel caso foste interessati a seguirlo. Per quanto riguarda invece la nostra rete, parto dal descrivere perché diciamo è stata attuata e risottolineo come i nostri pazienti con malattia di Fabry, siano pazienti affetti da una patologia rara e multisistemica. Due elementi molto importanti, in quanto il fatto che la patologia sia rara implica che non tutti gli specialisti purtroppo siano al corrente della patologia nella maniera corretta e il fatto che sia multisistemica implica che il paziente dalla diagnosi al successivo follow-up e all'approccio terapeutico venga seguito da specialisti di diverso genere. La nostra rete fa sì che il paziente abbia quindi un approccio centrato proprio sul paziente e personalizzato che sia volto a promuovere diciamo, la prevenzione della patologia e la consapevolezza della patologia in generale, che venga gestita la patologia con una terapia di ultima generazione, quindi con la terapia migliore disponibile e appunto che venga gestito il paziente riducendo quindi la sintomatologia ad esso associata e tutte le complicanze delle malattie. Risottolineo come sia fondamentale la cooperazione all'interno della rete tra i diversi specialisti proprio per gestire il paziente e la sua patologia. Nella nostra rete noi promuoviamo diverse attività, come ho detto prima, ci occupiamo non solo della diagnosi ma anche di tutto l'approccio poi del follow-up e della terapia del paziente step by step, sempre con un approccio multidisciplinare. Infatti all'interno della nostra attività possiamo sì fare diagnosi ma anche seguire il paziente per quanto concerne l'approccio terapeutico, come detto, quindi sia per pazienti che fanno la terapia enzimatica sostitutiva che prevede quindi una somministrazione per via endovenosa che soprattutto nelle fasi iniziali va eseguita in ospedale con monitoraggio da parte del personale medico ed infermieristico ed anche pazienti che fanno altre terapie come la terapia sciaperonica. Inoltre abbiamo come obiettivo quello di testare l'efficacia di queste terapie ed eventualmente ce ne fossero di nuova generazione anche dei nuovi approcci terapeutici. Il follow-up dei pazienti deve essere veloce e facilmente accessibile. Noi ci occupiamo di eseguire sia esami di laboratorio che visite ambulatoriali che esami strumentali. I percorsi devono essere personalizzati sulla base dell'espressione clinica della malattia, dell'età dei pazienti e della reale indicazione clinica. Spesso i nostri pazienti vengono da province che non sono nella nostra e quindi è auspicabile che riescano ad eseguire gli esami sia laboratoristici che strumentali nel più breve tempo possibile, proprio perché spesso alcuni esami e il risultato degli stessi fanno sì che il paziente inizi la terapia e che nel più breve tempo possibile. Attualmente noi ci occupiamo di 8 pazienti con malattia di Fabry. Recentemente abbiamo appena avuto una nuova diagnosi e appunto questi pazienti con il nostro team multidisciplinare, che è composto dai Nephrology, quindi dal professor Maurizio Gaglieni, dalla dottoressa Caruso e dal nostro personale infermieristico, dalla caposala Rosalia Franchetti, da Ilenia Ferrario e da Marta Minora. Nel team dei cardiologi invece ritroviamo la dottoressa Caracciolo, la dottoressa Camporeale, che si occupa di eseguire le risonanze magnetiche cardiache presso l'ospedale San Donato, e l'infermiera Argentina Romano. Tra i neurologi ritroviamo invece il dottor Pantoni e il dottor Mele, tra i oculisti il professor Staurenghi e la dottoressa Salvetti, come otorini invece il professor Bottero e la dottoressa Finati, e come genetista di riferimento abbiamo la dottoressa Luigina Spaccini dell'ospedale Buzzi. Un punto fondamentale della nostra rete è che è una rete aperta, ovvero sebbene il nostro team sia ben consolidato, noi siamo disposti e aperti a collaborare con specialisti che non rientrino all'interno dell'azienda sociosanitaria o comunque del team, così che se un paziente diciamo venga seguito, comunque se la diagnosi venga fatta da un altro specialista proveniente da un altro ospedale, possa comunque esso fare riferimento a noi magari per il follow up o per determinati esami e continuare ad essere seguito per esempio dal cardiologo o dall'oculista che invece l'ha sempre seguito, che ha fatto la diagnosi. Questo è un punto molto importante perché non sempre è possibile che ci sia un'apertura di questo tipo. Volevo sottolineare appunto che come altri obiettivi abbiamo quello di sensibilizzare non solo gli specialisti ma anche i medici del territorio su questa patologia, in quanto spesso ricevono dei pazienti con sintomi caratteristici e non riescono ad associarli alla malattia di Fabry. Questo per noi rappresenta un problema perché la diagnosi viene fatta tardivamente, spesso non viene proprio fatta, e come complicanza abbiamo che il paziente quindi rischia di avere un danno d'organo maggiore e che la terapia non venga effettuata tempestivamente, quando noi tutti sappiamo che oltre a migliorare la qualità di vita, diciamo, funziona meglio tanto prima viene incominciata. Grazie.
Bene, grazie Costanza. L'obiettivo era quello appunto di presentarci un pochino, quindi se ci sono domande siamo lieti di rispondere, ma non credo che questa presentazione si presti a domande specifiche sulla malattia. You do have a question, please.
Yes, hi, very nice presentation, Mr. Alberto Ortiz. I have a question regarding funding. So for the patients from extra network from outside, who is paying for the care?
I can answer to that. We have a national health system, so the big issue is transport, because the national health system will not pay for transport, let's say, from another area of the country where you have to take an airplane or a train. So that is on the pockets of the patients. Okay. But otherwise, for treatments or diagnosis tests, everything will be covered by the national health system. And once you have a diagnosis of Fabry disease, there is, we call that a note, a specific exemption from, I would say, all of the tests and blood tests or diagnostic tests that are needed for the disease. Okay. So patients are well covered on the clinical part, but if they have to travel, that is a little bit of a problem. But in Italy, there are many hospitals with doctors taking care of Fabry patients. So we have a different organization. Let's say if we consider the United Kingdom, there are big centers with hundreds of patients. In Italy, there are more centers with a lower number of patients. So there are plus and cons. So probably with many patients, you have more experience. But with a lower number of patients, probably patients are closer to the hospital. And also the personalized care usually is better because
the follow-up is better.
You know everybody. So the relationship is actually much more family style, I would say, rather than being in a center with hundreds of patients where probably the doctors cannot physically actually remember everybody.
Okay, great.
Va bene, io vi ringrazio.
Posso aggiungere solo una cosa? Volevo
Prego,
sottolineare
Costanza.
come la nostra rete sia efficiente, proprio perché una delle 2 recenti diagnosi che abbiamo fatto di un nostro paziente è stata fatta proprio dai nostri colleghi oculisti, quindi un caso molto interessante di un paziente che aveva cornea verticillata e una neurite ottica, e sono stati proprio loro ad indirizzarci poi il paziente per le relative visite e il follow up. Quindi volevo
Esatto, questo paziente era andato dall'oculista perché praticamente ha perso la vista da un occhio per la neurite ottica e l'oculista ha indirizzato il paziente a noi perché probabilmente conosceva già la questione cornea verticillata, ma se si sa che c'è anche un centro che si occupa della malattia è più facile che lo invii. Infatti posso raccontarvi di una paziente che I want to say this case report, a patient of mine for 2 reasons. One is that a woman in her late 30s, this was something like 15 years ago. So she comes to the nephrology clinic because of proteinuria, no other problems apparently. So something like 1.5 to 2 grams of proteinuria per day. So we make a kidney biopsy. So I do the biopsy. And then a colleague of mine, Dottoressa Volpi, was there with looking at the biopsy sample. So she turns at me and she says, you know, I don't see any glomeruli. It's all white. And there are some kind of projection. Maybe you got intestine because there are intestinal villi. And I said, no, that's impossible. It's under sonography. I'm sure I got the lower pole of the kidney. I cannot get, so the biopsy samples go to pathology and it comes out that it was Fabry disease. When I went through her analysis to her previous documents, turns out that she was seen by an ophthalmologist when she was 20 or something like that. And he described the cornea verticillata. But at that time, there was no treatment. So he told, no, don't worry, that will not affect your sight. You're doing fine. So that demonstrates the big change, because at that time, he did the diagnosis, but he just even not informed the patient that there was a genetic disease.
Not to worry her.
And not to worry her, that's correct. And now we have this case where the ophthalmologist was aware of the disease and was aware that there is a treatment and that there is a Fabry unit in the hospital. So that is actually, Costanza, thank you for pointing that out, because it's the very essence of a network.